Thanks everybody for joining. And I have to say this is my first webinar ever, so hopefully you'll cut me some slack here. But no, and we're joined by Sarah tonight, and Sarah Campbell is a physical therapist with Avalanche Physical Therapy, and she's going to be speaking a bit too. And I want to thank Rachel on the other end who's arranged all this. So I want to also thank our research foundation who's behind these educational talks. So just a brief outline, we're just going to talk a little bit about the numbers in shoulder pain, some anatomy, presentations, treatments, rehabilitation, and then at the end, we welcome any and all questions. So, but shoulder pain, it's a big problem. We see shoulder pain commonly in the office, especially I do primarily just shoulder and knee. And about a third of our population has at some point complaints of shoulder pain. And that equates to about 4.5 million people that visit their physician for shoulder pain in a given year. Of shoulder pain, rotator cuff problems are the #1 cause of shoulder pain. So there's other causes like arthritis in the shoulder, fractures, other things, but rotator cuff problems are by far and away the #1 source of shoulder pain that we see in the office. So some just basic anatomy. This is looking at the bones of the shoulder, and basically we have our humerus and the humeral head, and on top of the humeral head there's a coating cartilage layer, and then the glenoid is the socket, and the socket is actually part of the scapula. But in our shoulder joint we all have this nice glistening cartilage that coats the ball and the socket side, and then our collarbone lives above our scapula and our glenoid. And then as far as what is the rotator cuff is really 4 muscles and tendons, and the tendons form a cuff around the humerus, and they help power the shoulder. And so if you look on the right here, this is a front view of the shoulder. You see that there's one of the rotator cuff muscle tendon units is called the subscapularis. So it's a muscle that then becomes a tendon, and the tendon hooks on the bone. And then the supraspinatus is this muscle that is kind of on the top of our shoulder up here. And again, it's a muscle that becomes a tendon, and the tendon hooks on the bone. And then if we look at the shoulder from the back, similarly, we have our infraspinatus and this small muscle tendon unit below it called the teres minor. So those 4 muscle tendon units make up what we call the rotator cuff. And again, they power the shoulder. So for instance, the supraspinatus, which is honestly the tendon that we most commonly see that tears, it raises our arm in this plane of motion. The subscapularis, this big muscle tendon unit in the front, it rotates our arm inward. And then these muscle tendon units in the back, they act to rotate our arm outward. So they each have a function. And as we'll see when we talk about a physical exam, we can oftentimes determine in the office which of these muscle tendon units has been possibly torn or injured. So rotator cuff disease. We'll start there. It's really a spectrum. Rotator cuff problems are really a spectrum. And I'd say, people oftentimes just present with what we call subacromial bursitis. And this is really a catch-all term, and you might hear it called other things, which is actually equivalent. So rotator cuff tendonitis and impingement syndrome and subacromial bursitis, these are really all the same things. And this drawing really shows this. Basically, here in this case, the supraspinatus tendon can get some inflammation in the tendon fibers, and there's naturally a bursa. It's a fluid-filled sac that lets the tendon glide underneath this bone called the acromion, and this bursa sac can become inflamed and thicken, and oftentimes it can pop and crack and cause pain along the side of the shoulder. We see the biceps tendon. This is not one of the rotator cuff tendons, but it comes up between 2 of those tendons. And oftentimes that biceps tendon is involved with rotator cuff problems. But then, things obviously can progress and people can actually tear their tendons. And this is just a diagram of a torn supraspinatus tendon. And so you can see this defect in the tendon here where the tendon fibers have actually ripped off the bone. And so these tendon fibers are intact, they're still attached. But here we see areas where the tendon has actually pulled away from the bone. And so when we say a rotator cuff tendon tear, that's what we mean, where most of the time the tendon is actually just pulls away from the bone. Although it is possible, I just had a woman in the office last week who actually tore her tendon here in the central portion of the tendon, so she didn't tear it away from the bone. But 99% of the time, this is what people do when we talk about a rotator cuff tendon tear, is the tendon actually pulls off of the bone attachment. So what are the symptoms? What are patients going to complain of when they may have a rotator cuff tear or a rotator cuff that's inflamed? Number one is pain. People will just say, my shoulder hurts. And usually people will comment on the fact that their pain is worse at night. It wakes them from sleep. That's very common with rotator cuff pathology. And then the pain itself, most people will say, it hurts here on the side of my shoulder, in the front of my shoulder. Those are the most common areas, is people oftentimes grab right here and say, my shoulder pain is right here. So it's not up, in the neck. People can get some pain in the back around their scapula if it's long-standing, because we're oftentimes compensating with our scapular muscles. But shoulder pain, typically, rotator cuff pain is typically here. And then weakness is the other thing. People will complain of weakness in their shoulder. People will say, I reach into the fridge to try to grab something off the top shelf and I just can't do it. Or I'm trying to put, dishes away on a top shelf and it's difficult to do. Or even getting a coat on, reaching for my purse in the back seat, I just feel really weak. Or I'm in the gym and I just can't do any kind of overhead strength training. So those are the two most common things that people will complain of, is pain, number one, weakness, number two. So what are the causes of rotator cuff tears? Honestly, it's really just wear and tear, and it's due to aging. So as you and I and we all get older, our tendons aren't the nice glistening tendons that we had when we were 20 years old. And I tell patients it's kind of like a fan belt in your car. Oftentimes you get so many miles and then that tendon one day just tears. It can be traumatic, like if you had a hard fall skiing, that can do it. But honestly, most of the time, 9 out of 10 times, there's not one event that people will comment on. It's just people will say, my shoulder's been killing me for 2 months and I don't recall doing anything and it's waking me up at night. So, but it's usually tendon degeneration as we get older. And if we do, there are studies that have been done where we just MRI people on the street and we look at their rotator cuffs, and we see that in the fifth decade of life, about 13% of patients have rotator cuff tears. In the sixth decade of life, about 20% have tears. And in the seventh decade, about 30% have tears. And really, because of it's aging, but it's really a vascular compromise. We just don't have we lose that same blood supply and nourishment to the tendon as we get older, and that helps predispose it to tear. And a lot of these tears are asymptomatic. If we again MRI'd 100 people on the street and looked at their shoulder, let's say in a group of 60-year-olds, we'd see about, maybe a third that have rotator cuff tears. And you might find though that about half of those are symptomatic and another half are asymptomatic. They don't have symptoms. As far as the other cause, injuries are definitely, we see those as well here in ski country. If someone has a fall skiing and they dislocate their shoulder over the age of 50, we always have to be worried about a rotator cuff tear. A 20-year-old that dislocates their shoulder isn't going to tear the rotator cuff, but a 50-year-old or 60-year-old that dislocates their shoulder can oftentimes tear the rotator cuff. Clavicle fractures, other shoulder girdle fractures can cause rotator cuff tears. So rotator cuff disease, it's kind of, we see it as it's a spectrum. It starts with tendinopathy or this chronic tendonitis in the shoulder, and then the tendon starts to partially tear away from the bone, and then it results in a full tear. And if it goes untreated or unnoticed, a full tear, then the tendon, once it tears off its attachment site, it starts to slowly creep away, pull away from that attachment site. And that's what we call tendon retraction. And that's a worse problem, as we'll discuss. And then once the muscle tendon unit is not attached to the bone, the muscle isn't seeing any stress. And so the muscle will atrophy. And initially you'll see the muscle fibers get smaller on an MRI, let's say, but then eventually we see a process called fatty infiltration where actually the muscle cells will be replaced by fat cells. And unfortunately, once that happens, that's not reversible. So that's why we don't want to get to the point where someone has a big retracted tear and their muscle is basically mainly fat, because we might be able to fix that tendon, but patients won't necessarily get a lot of their strength back. And so those are really in severe end stage type tears. So what are the risk factors? Who do we see these tears in? It's typically, you know, patients that have done a lot of repetitive overhead work and lifting. So if someone tells me, you know, I've been a master swimmer for 30 years, you know, oftentimes they have some issues with their rotator cuff. If someone says, yeah, I love weight training and I've been pushing heavy loads in the gym for 30 years, again, high incidence of rotator cuff tears. Tennis players, racket sports, overhead athletes. And then as well in the trades, you know, someone that's a painter, a carpenter, someone that's working overhead and doing a lot of overhead lifting, that can just, again, cause that wear and tear change in the tendon and eventually cause it to tear. And then we see higher incidences of tears in smokers. And again, the reason is that smoking compromises the blood supply to the tendon so it can't heal itself. And therefore, it's more likely to tear earlier in life. So what do we do in the office, whether you come see Sarah or myself in the office? First of all, we're going to look at your shoulder. We inspect the shoulder, look for atrophy of the muscles. We always compare to the other side if it's a normal shoulder on the other side. And then we'll palpate, you know, pushing on various areas of the shoulder, basically where the tendons attach to see if you're tender over those areas. And then we just want to check your range of motion, make sure you don't have other things going on like a frozen shoulder. I had a gentleman in the office today, he had a rotator cuff tear, but he also had a frozen shoulder where he's so stiff he can hardly move his shoulder. Is there the other cause of loss of motion in the shoulder is arthritis, so we want to rule that out as well. And then we do a good strength assessment. So basically we're just resisting you in various directions to determine if possibly you've injured or torn your supraspinatus, your infraspinatus, and your subscapularis. And we have specific muscle tests that we do that isolate those groups, those various muscles to determine if one is weak. And then imaging, you know, we'll start with just a simple x-ray in the office because we just want to, first of all, just see, you know, do you have arthritis? Is there any kind of bone-on-bone contact in the shoulder? Is there calcium in the tendons? Because calcific tendonitis, we call it, is kind of this chronic inflammation of the tendon that can predispose someone to tear their tendon. Did you have an old fracture that you didn't know about that then maybe predisposed you to tear your tendon? And then oftentimes an MRI. And with an MRI, again, the x-rays are just going to show us the bones. The MRI is just going to show us all the soft tissue and the bones. So we're going to see the tendons, the muscle, the cartilage. And so we can see, is a tendon torn? Is the tear retracted? Is it pulled away from its attachment site? And then we look at the muscle itself and look at the, you know, see if the muscle's healthy or if there's that atrophy and that fatty infiltration of the muscle tissue. So here's an MRI just from the office, and just to point out a couple of things. So this is your humeral head, that's the ball. Here's the glenoid, that's the socket. The white that you see is inflammatory fluid, and this person has evidence of some inflammation in their shoulder. And then this is their supraspinatus muscle, and then this portion is their tendon. But the problem here is that that tendon attachment should be way out here. And it's not. So that's a good size rotator cuff tear. Luckily, it's still fixable for them, but that's a large tear. So how do we treat these rotator cuff tears and rotator cuff disease? Like if it's just rotator cuff inflammation and impingement syndrome, and maybe a little partial tearing where the tendon is kind of peeled up off the bone attachment a little bit, it's not surgery. Typically, we're doing physical therapy, sometimes an anti-inflammatory or icing the shoulder. If the shoulder is really painful and one can't really participate in physical therapy, or they can't sleep at night, let's say, then we'll probably do a steroid injection. We may consider a platelet-rich plasma injection, although the evidence for that is honestly somewhat weak, and we'll talk about that a little bit. And then we want to modify activities that are causing pain. So if someone's saying, you know, I'm in the gym 3 days a week lifting weights, or I'm in the pool 3 days a week, we're probably going to back off on that activity just to give the tendon some chance to calm down and try to heal itself from the inflammation. So PRP, a lot of patients are asking about PRP and stem cells. And, you know, unfortunately, there's a lot of direct-to-consumer marketing with this stuff, and there's not a great deal of science behind it. We're developing more science behind it. And there are some indications that it can help in certain conditions. But honestly, as of today, there's really insufficient evidence to show that PRP helps to heal rotator cuff tears, or it's even helpful in terms of decreasing inflammation. You know, I have patients that are adamant that want it, and I'm happy to arrange for it. It is fairly expensive. It's about $1,000 in the office by my partner who does a lot of them. And again, I'm happy to arrange it, but as of today, the evidence for it is somewhat weak. We haven't seen improved healing with PRP or stem cell injections when we add these to rotator cuff repair surgery. There have been some studies, though, to show that if someone, let's say, has had a prior rotator cuff repair, let's say 15 years ago, and then they come to me and they've unfortunately retorn that tendon, that in a redo setting, a revision setting, that adding a PRP can help healing rates a little bit. So I use it in some instances. So what about complete tears? So if someone, again, has torn that tendon completely off the bone, physical therapy helps and surgical management helps. They both improve symptoms. However, if we don't do surgery, we find that the natural history of these tears is such that they get bigger, more tendon pulls away, they get more retracted, you can get more of that fatty atrophy as a result. And then all these things progress without surgery. And studies have really shown that a healed repair shows improved outcomes over non-surgical management. So, most active people that we see here in the mountains, I recommend for any full thickness rotator cuff tear that they get it fixed, because the healing rates are good. We don't have, a ton of smokers or people that aren't, people here are into their health. They want to get better. And those people are typically going to heal their repairs and do very well, although it is a long recovery, as we'll talk about. In the US today, in a given year, there's about 250,000 rotator cuff surgeries performed. About most of these are done, 65% or so in people that are still of working age, so under the age of 65. And we've looked at studies where we compare the cost of surgery, which is significant, but the offsetting costs of someone that is no longer able to do their job, as, let's say, as a carpenter or as a painter or someone like that. And actually, we've demonstrated convincingly that we can, save society money by getting these people back to work and getting them a shoulder that works. So I was just going to show one video of a rotator cuff repair, and I don't know if, I just wanted to put a little caution out there if people don't like to watch that kind of thing, to maybe turn your head away. It's just looking through the camera into a shoulder with a torn rotator cuff. So here's the torn tendon up here. Here's the bone down here. And I've actually prepared the bone. You can see the bone is all bleeding. So I use this high-speed burr on the bone. We want to get all your stem cells out of the bone. And then the goal is to get this tendon reattached down here to the bone. And we use these little suture anchors, they're called. And they're tiny little devices. They're about 4 millimeters in diameter, maybe about 8 millimeters in length. And today we use implants that are not metallic. They're made out of a material that will turn the bone over time. And we actually just thread them into the bone here against the cartilage. So here's the ball, here's the socket, here's the torn tendon, and the tendon needs to come down here. Here, for instance, is intact tendon back in here. And so we put these little bone anchors in. Off of the bone anchors come suture, and we pass those sutures up through the tendon. So we pass it up through the tendon here, and then the tendon is sewed back to the bone. So this is the kind of after picture. So the anchors are in the bone, and then the tendons bridge across the tendon, and they hold the tendon down to that exposed bleeding bone, and then the tendon will heal into that bone. Here's another one. This is a subscapularis tear, and you can see the tendon, it's not attached in the front of the shoulder here. And in surgery, we do it through these little plastic tubes. We call them cannulas, but you can think of it as like a plastic straw that's really strong and thick. And it's bigger than a straw, though. It's about 8 millimeters in diameter. So all the instruments come through these plastic tubes, and we usually can do it through 2 or 3 tubes in the shoulder. And then we're taking this torn tendon and sewing it back to the bone out here. So this is the after picture. And I have this little probe, this metal probe. I'm just probing to make sure the repair is in place. And that's the repaired tendon right there. So who are the patients that are not going to maybe heal after a rotator cuff repair surgery? The factors that work against us in terms of healing these rotator cuffs are, number one, large tears. So the larger the tear, like if you've torn 3 tendons away from the bone, the success rates with surgery are lower. Retraction. So if the tendon is torn off the bone, but it's sitting right above where it belongs, I know I can get it right back down and get it to heal. It's going to heal well. But let's say the tendon is really retracted. As I tell patients, it's like stretching a rubber band over. And oftentimes we can stretch it over, but if that repair is under tension, it has a higher failure rate and it could re-tear and not heal. Increasing age. And again, that gets back to these tendons aren't the tendons that you or I had when we were 20 years old. And they've seen some wear and tear change. It's like a frayed rope. It's not that nice rope we had when we were 20 years old. And so the biology, the healing environment is not as good when we're 80 as when we're 20. And then if there's fatty infiltration of the muscle, we can sometimes get the tendon to heal, but people will still be weak. They might even still have some pain. So we want to get to these before you get to that point. Smokers, diabetics, unfortunately, they have a higher risk of not healing rotator cuff repairs. So, one problem that I see not infrequently in the office is, what do you do with let's say the 50-year-old with a massive, severely retracted tear that's not fixable? So the tendon is so far pulled away, there's just no way we're going to get it back over. And as of maybe up till 6 years ago or so, what we would honestly typically do is we repair the tendons we could repair. So we repair the ones in the front or the back of the shoulder. The one on the top is oftentimes the one that won't come over. That's called the Supraspinatus. And we'd oftentimes just say, sorry, that's as good as we can do, is get 2 of your 3 tendons fixed. And people would do okay with a partial repair. But for instance, this is an MRI of one a patient I saw in the office. Here again, we see here's the ball, here's the socket, this is the bone above the shoulder, here's that rotator cuff muscle, but here's the tendon right here. And there's just no way that tendon is going to come all the way out here. So, and we know that based on the MRI scan. So in the office, I would counsel the patient, say, hey, I'm sorry, you're tough because you've lived with a tear for many years and it's so far retracted, it's not fixable. Now, on other slices of the MRI, I might see other tendons that I can fix and say, we can fix those. But one thing that I've been doing now for about 5 years in these massive tears, and I think it's led to definitely better results, and our literature would support that, is something called superior capsule reconstruction. And really, the way I tell patients is, we're taking a piece of donor tendon and we're sewing it in place of the irreparable tendon, but we honestly can't connect it to the muscle. But what we do is we connect it to the bone on the socket side and on the ball side out here. And as we say, it acts as a trampoline to help hold basically the ball in the socket, because without it, the ball wants to ride up. So it kind of holds the ball in the socket. And then the other tendons that we can fix, like the subscapularis, the infraspinatus, if they require repair, if we can get them fixed, then patients can do very well, because it allows those other muscle tendon units to have their normal mechanical advantage and still be able to therefore get our strength back. So this has been really groundbreaking and a real, I think, benefit to patients with these bad problems, these severely retracted irreparable tears. And this is kind of what it looks like if you're looking at a cross section of the shoulder, where this donor tendon, it's actually a dermal, it's a thick skin graft, believe it or not, and we anchor it to the socket and the ball out here, and we say it acts as like a trampoline effect. It kind of holds the ball down. So we talked about the results of what it can accomplish here. So here's a patient with one of these massive tears. Here's the ball you saw over here, the socket. There's just no tendon to repair. They're just not a candidate for repair. They had a tendon in the front of their shoulder that I could fix and one way in the back that I could fix, but the one on top is just not fixable. And this is what it looks like afterwards. So here's that donor tendon. It's a dermal allograft actually, and it's all sewn in place on the top of the socket over here. And then out here over the edge of the socket, the edge of the humeral head out here. So this has been definitely a big improvement over what we could offer patients even 5-6 years ago. So the last problem to discuss is, what do you do with a patient who has a massive retracted irreparable rotator cuff tear and they have severe arthritis in the shoulder? So maybe they have some bone-on-bone contact between the ball and the socket. This is a typical x-ray of that finding. So here we can see that here's the ball, here's the socket, large bone spurs down here. And there's normally a big space between this bone, the acromion, and the ball. It's about a ½ inch space, because in that space is our rotator cuff tendons. But in this patient, there's no space. Their ball is actually rubbing on this bone above. And that tells us they have a massive tear. It's very retracted. We oftentimes will get an MRI and it'll show that basically there's no muscle left. It's all fat, replaced with fat basically. So here's the ball, here's the socket, and there's just no muscle left. So in that case, we're looking at a massive tear and arthritis. really this is your best option. It's called a reverse total shoulder. And it's kind of a funny design, but basically we put the ball on the socket side and the cup on the humeral side. And in so doing it moves the center of gravity of the implant such that the deltoid muscle, this muscle out here, has its best mechanical advantage and then can still act to raise our shoulder. So that's a really good option in that difficult problem of a really bad tear and arthritis. But we don't want to do this in a young patient, you know, so typically we're trying to get someone till at least age 65 until we go to this solution. Just because if you put it in, let's say a 45-year-old, a 50-year-old with that problem, they'll wear this implant out prematurely. And you might get one redo on this in your lifetime, but that's about it. So we don't want to go to this unless someone is of that age where maybe, you know, it's going to be the last surgery they ever need, or possibly they need one redo. I think that was all I was going to talk about. And I was going to turn the mic over to Sarah to talk a little bit about physical therapy.
Sounds good. Thanks, Dr. Cunningham. So I'm Sarah Campbell. I work for Avalanche PT in our Silverthorne location. I graduated PT school in 2017 and have been working in the county since. So I've been working with the guys over at Vail-Summit Orthopedics for the past 3.5 years. And yeah, I think we've worked pretty well together so far. Definitely seen a lot of the rotator cuff repairs come out of that office. I would say it probably rivals the amount of ACL repairs we see coming out of there. So lots of shoulder injuries in our county, lots of active people. So in terms of like a PT's role, we're also trained in the diagnosis of shoulder injuries. So we're a direct access clinic. I got my doctorate in physical therapy, so we're trained in differential diagnosis and making sure you're in the right office, basically, so we can refer out to a physician if need be. So we can do all the same special tests that they're going to do in the office, and then we can recommend whether you're going to need an MRI and see them in Frisco or Vail Edwards area as well. So basically when you come into the office, we do testing of the muscles, range of motion. We've got a couple special tests just to kind of nitpick and see where the pain is coming from. And then I think the biggest thing is that we can offer is giving you exercises to reduce the pain. So if you have an appointment with a physician later on too, we can kind of get the pain hopefully reducing with some light motion exercises, some muscle activation exercises, and hopefully get you a little more comfortable, maybe sleeping a little better, because I know a lot of times shoulder injuries really bother that sleep. You can go ahead and move on to the next slide. And so if you do have to go through the surgical management, then you're going to see a lot of us, because it's a pretty long rehab following, but it gets you back to everything that you need to be doing, want to be doing. So there's kind of 3 different stages that you go through, and we're really involved in those first 2 stages and then kind of make you more independent in that last phase. So go ahead and we'll start with that first phase, is that passive range of motion. So this is depending on how long Dr. Cunningham wants you to kind of stay resting. Usually you start in PT at week 4 or so, and we just start moving the arm for you. So just gentle motion, kind of within pain thresholds, but usually people are like, it feels so good to get my shoulder moving after being in a sling for 4 weeks. So we're usually a good friend at that point. You're still wearing that sling 24/7, can kind of take it off to stretch the elbow out, depending on if you had any bicep issues. Sometimes they'll guard that bicep a little bit more. And then we're also working on a little bit of posture education. So a lot of times when you have shoulder injury, that shoulder kind of drops forward and in, and that actually causes more pain. So we like to get you sitting up, nice good posture, shoulder blades activated, make sure your neck's not bothering you. Just kind of keep you comfortable in that first 1.5 months. Go ahead and, yep. And so the second stage, we start having you move your shoulder more, getting you to use pulleys, the wall, tables, whatever you can to kind of help get that arm moving and actually using your muscles a little more actively. We'll keep stretching you just to make sure that we're getting the range of motion that you need to get back so you can reach fully overhead and behind your back and across your shoulder. And then we also start strengthening a little bit at this point. So we kind of stay away from those rotator cuff muscles, but we can start with some shoulder blade strengthening, get that posture strengthening, again, taking some pressure off the neck, some pressure off the shoulder. And really in this stage, you're feeling a lot more normal. You can get back to more of your normal daily activities, showering, sleeping, working around the house. And yeah, we want to get to your motion pretty full in the first 3 months so that you can be getting to use that arm a little more normally. And then stage 3, this is the fun stage, but it's also the longest. We start at week 12 with some light rotator cuff strengthening and just kind of keep progressing you as you tolerate. Everyone's a little bit different in this stage. And typically it can take up to a year to get your full strength back, but we'll see people in PT for 4 to 6 months, really working that strength and stability and making sure you can do all the sports that you're interested in doing in the future. So we do a lot more rotator cuff strengthening, really working those posture muscles, getting some stabilizing muscles going so that you can put some weight through your arms, you can ride a bike, do yoga, crawl around on the floor, whatever you need to do really. And really we use your goals to progress. So whatever you want to get back to, we'll push you as hard as you want to be pushed. And then that return to sport is the final goal. And that's just making sure you're stable so you're not going to dislocate again, you're not going to injure that rotator cuff, and getting everything strong and controlled and making sure you look as normal as we can get you looking. And
sorry.
Yeah, no. So like I said, we see a lot of these, and I mean, I think this stage 3 is the most fun because we actually get to see you back to doing the things that you love to do. So I will be here hanging out, taking some more questions on PT. But like I said, we work with whether you're having surgery or not, just making the shoulder feeling better, getting you doing what you want to do. So I'll turn it back over to Dr. Cunningham.
All right, yeah, and just a couple more things to share. Obviously, you know, COVID has been a scary, disruptive time. We're still seeing patients as per normal. First time I could take my mask off today and having to wear my goggles and things, but we were happy to evaluate you in the office, and we're following all the necessary protocols to keep you safe. We have offices in Frisco, Edwards, and Vail, and Avalanche in Frisco, Silverthorne, and Breckenridge. Have our websites here if you're interested, our phone numbers. Yeah, again, this is my first webinar. I think it's been fun. We're going to take questions. I just wanted to bring your attention to the fact that I'm going to do one more of these February 4th, and we're just going to talk about common knee injuries, particularly as it pertains to snow sports. You know, we're seeing, you know, unfortunately, a lot of injuries here with ski season upon us. So anyways, Rachel was going to shoot some questions at us, just in case, you know, if we had a couple questions that were similar, she would maybe summarize one question that represents those. And yeah, happy to field those questions. So I'll turn it over to Rachel to have her let us know what's of interest to people.
Thanks, Dr. Cunningham. And I just want to let everybody know that February 4th webinar, I'm going to be sending a link for to register for that. So check the chat box. I'm going to be sending that over shortly. All right. So we did a few questions already. Let's see. I took a forward slow speed fall when cross country skiing last weekend. I put my right hand out in front of me to stop my fall. There was an immediate extreme pain in my shoulder and I had difficulty raising my arm. I applied ice packs and took ibuprofen for the first few days. I have a large dark bruise on my bicep. The pain has diminished and I can raise the arm, but with moderate pain. Do I need to see a doctor?
Yeah, a little bit depends, that scenario, on honestly a little bit someone's age. So if it was, let's say you're 60 years old and you had that happen. The most common thing, and I have my little handy duty shoulder model here. I don't know if you can see that, but is when you have an outward when you fall on an outstretched hand like that, basically the ball comes up and kind of jams under that bone above it called the acromion. And you can have some bruising where the rotator cuff attaches actually within the bone. So there can be blood in the bone where the rotator cuff attaches. And then some people will tell me, oh gosh, I can't even raise my arm at all. And then a week later, oh, it's getting better, I can raise it. 3 weeks later, you know, almost full range of motion, minimal pain, sleeping through the night. By 5 to 6 weeks, back to normal. So I think because you've seen such a nice progression and are feeling better, that we can assume it's just a bone bruise and you're doing well. But if at any, let's say you're 2 months from the injury, 3 months from the injury, and you said, gosh, ever since that injury, I've continued to have this nagging pain. It's waking me up at night. I just feel like I've lost some of my strength. Then I would get evaluated. But if in 6 weeks, let's say you get back to your normal and you have full motion, no pain, good strength, then you can assume it's just a bone bruise and you probably didn't do anything more than that. And Sarah, feel free to add to anything that I say.
Yeah, I mean, you can always stop into PT and see if the exercises are helping. Sometimes we'll have people just do exercises for 2 weeks. And if you get benefit and can get your arm back overhead, then you probably don't need to follow up with a physician. But you can always stop in with PT and see if it'll get moving a little better than on your own.
We have another question. Post-surgery, why does one experience nerve pain throughout the arm? Why is it more painful lying down? And what is the infection rate?
Okay, yeah. So I'm on the surgery committee, and we look at infection rates. And honestly, our infection rates at the surgery center, for instance, and even at the hospital are incredibly low. It's about 3 in 1,000 for all orthopedic surgeries combined. And even when you break those out further and you look at arthroscopic procedures like rotator cuff repairs, it's much even lower. It's probably 1 in 2,000. So risk of infection extremely low. We can't take all the credit. You know, if you compare those rates to, let's say, Denver rates are probably 3 to 5 times higher. But the reason for that is we have such a healthy population. So, you know, a 70-year-old patient here is oftentimes out hiking a 14er and skiing and doing all these things, and they're not a smoker and their weight's under good control. Versus, unfortunately, a 70-year-old in Mississippi or in other areas in the country oftentimes has a lot of comorbidities, a lot of other medical problems that predispose them to infection because they just don't have the same immunity that you may have. So, you know, but part of it is, I think we take really good care of our patients, and we're very strict about our protocols to prevent infection, but we can't take all the credit. A lot goes to you guys for just being healthy people. So that was infection. Nerve pain. So you shouldn't have nerve pain after surgery, honestly. As far as anesthesia, which I digress a little bit, the anesthesiologist with surgery today, what they'll do is they do a nerve block. So they numb up your skin here before you go into surgery. And with a needle, they localize your brachial plexus, the nerves that go down into your arm, and they inject some numbing medicine around the brachial plexus. And in recent years, in the last couple of years, they actually will leave a little tube in your skin, and it's connected to a little pain pack, and it'll infuse medicine in there and make it such that you have no pain typically for the first 2 to 3 days, which is great because rotator cuff surgery, even though it's arthroscopic, it's painful. It's hard to sleep and things. So that has been a great advance, is these nerve catheters that I use in all my patients, like probably for the last 5 years or so. They used to be just single shot nerve blocks where they just numb you up. It would wear off in about 12 to 18 hours. But once that nerve block wears off, you really shouldn't have nerve pain, like pain that radiates down into your hand. That's unusual. If you have that, then, you know, could there be a problem with your cervical spine? Could there be a pinched nerve in the periphery? Because nerve pain is not normal after rotator cuff surgery. Pain is normal. People have pain, and it's usually here, but it's not like this shooting electrical pain down your hand. That's like a nerve pain. And Rachel, there's one other part to that question. I think I forgot it already. There's a third part, maybe. It was nerve pain, and there was one other thing, I believe.
So it was, why is it more painful lying down, and what is the infection rate?
Okay, so we talked about the infection rate. Lying down, it's because we're doing all this work up here, and what happens when you lie down is because we've eliminated gravity, basically the rotator cuff in the area that we worked on will contact the acromion when you're lying down and pinch the area that we just worked on. So it causes you more pain. So it's very common after rotator cuff surgery for patients to say, I had to sleep in like a recliner chair for 3 to 4 weeks before I could sleep flat in bed. That, you know, I had to prop myself up in bed on some pillows. I couldn't sleep flat. So, and Sarah, I don't know if you have anything more to add to those questions.
No, I think you covered it.
Okay.
We have another person who wants to know more about the steroid shot in the arm and whether or not you think that's a good thing to do or not.
And it would depend a bit on your all those things that we went through, like your history, your physical exam. You know, if you came in and let's say I examined your shoulder and you were very weak in your rotator cuff testing, and I can tell with maybe 90% certainty whether you have a rotator cuff tear or not based on your physical exam. Some people can hide a small tear from me because they can make up with other musculature, but any large tear we can pick up in the office even before we get an MRI. And so if you had that sort of presentation, I would probably say, let's hold off on an MRI. We got to establish the diagnosis and make sure we're not masking a rotator cuff tear. So let's get that MRI first and see what that shows. But let's say we did get an MRI on somebody and we were concerned about a small tear and it turned out that it wasn't torn, that it was just an inflamed tendon or a low-grade partial tear where the tendon has started to peel up just a little bit, then absolutely an injection can work great. And it really calms down all the inflammation, because chronic inflammation around a tendon is bad for the tendon. It actually will predispose it to tear eventually. So we want to break that cycle of inflammation. So people are naturally concerned about steroid shots, but really the steroids we see problems with are those that are taken orally because they're systemic. We don't want to do a lot of shoulder steroid injections, but one injection is safe to do. And we would just calm your inflammation down and then send you to Sarah physical therapy and get you through this with no surgery if it's just an inflamed tendon or a low-grade partial tear.
So I had another person asked, I had a rotator cuff repair in 2006. Now I have a full thickness tear again in the same area. How successful is revision surgery? I'm a 57-year-old male and very active.
Yeah, and so at 57, your chances are good. If the tendon, the re-tear is basically, you know, it's torn off the bone, but it's not severely retracted. Again, if we see that scenario, then I could counsel you on your rates of success, but they're definitely lower if it's a severely retracted tear. But if it's just a re-tear, if it's of the same tendon, you know, and honestly, just like everything in medicine, we've gotten better. You know, I'm better fixing rotator cuff tears today than I was when I started in practice nearly 20 years ago. And the techniques have gotten better. And so, you know, it could be the case that at your prior rotator cuff repair surgery back even 10, 12 years ago, we were doing what are called single row repairs. So we take the tendon and we just take it and we fix it to the bone like so at one point of fixation. And today we're taking the tendon and we're doing a double row repair. We take the tendon and we basically reapproximate its normal attachment site. And we've seen improved results with that. And we have ways of releasing retracted tears and mobilizing them. So, and our implants are stronger. Everything is better. Unfortunately, you and I are both older. That counts against us in that scenario. But, you know, at 57, you probably should consider getting it fixed just because it's going to get worse. It's going to retract. It's going to cause you more pain. If you wait too long and it's really retracted, then it's kind of living with a painful shoulder until you're old enough to maybe warrant that reverse total shoulder that we talked about.
Okay. I have lived with partial rotator cuff tears for years, full motion in one arm and 60% in the other arm. Can still ski and lift most stuff. Should I talk to a physical therapist or a surgeon first?
Yeah, I mean, if you've had a partial tear that's been stable, let's say it's you know, 20% of the tendon is peeled up or 30%, no surgery for that. And honestly, even if someone came to me and they had a full tear that was completely off the bone, but they told me, listen, it doesn't hurt, I can ski, I can be in the gym, I can do all the things I want to do, I'd be hard pressed to try to tell you to have surgery. I would just tell you that the natural history is not good of a tear that's fully off the bone. But in this case, a partial tear, physical therapy, yeah.
And I just wanted to mention one thing. I realized we're working with a lot of people who probably have Medicare. And if you have Medicare insurance, that's the only one that's not direct access for PT. So you do need to see at least your primary care to refer you to PT.
We have a couple shorter questions that I kind of want to just rattle off to you, Dr. Cunningham. What sleeping positions aggravate shoulder pain? And then what is your view on using ice versus heat?
Okay, yeah. Sleeping positions, you know, everyone's a bit different, but I would say the most common things I hear are laying on the shoulder can cause pain. I wouldn't tell a patient it's doing you further damage. So if you know you have a small tear, let's say, or a partial tear, you can sleep on it if you're comfortable. It's just a lot of patients won't, you know, they'll lay on the shoulder and then it'll wake them up. And then being somewhat upright tends to help people. And I must be brain dead, Rachel. What was the other question?
So the aggravated shoulder pain during sleeping, and then view on using ice versus heat.
Oh yeah. So people, I would say you know, often find it's comfortable to heat the shoulder up. So, you know, Sarah might apply some heat to the shoulder before she works here in the office, but then we tend to cool people down afterward. And that, you know, cold has been shown to be a potent anti-inflammatory. And so, you know, let's say you do some rotator cuff exercises that Sarah shows you, some band exercises, some stretching, then afterward, you know, ice the shoulder down. I think that's a good routine. So whether you heat it ahead of time, then do your exercises, or you just get the shoulder warmed up with the exercises, then ice it afterward.
With 31% of rotator cuff repairs occurring in the 7th decade of life, if the patient has one of the two surgeries, what kind of possible complications are you looking at?
Yeah, and that statistic, maybe I misspoke. It basically, if we took 100 people off the street just randomly and we put them in the MRI machine and we looked, about a third of people would have rotator cuff tears when they're in their 70s. And actually that was the 7th decade, so it's even higher if you're in your 70s. It's probably 40%. But of those people that have tears, we find that about half, maybe a little more, have symptoms, you know, where they say my shoulder hurts, it's painful, and that's what might lead them to see the doctor. But there's a certain percentage, 40% or so, where people say, of that random sampling, that we might see a tear and we say, how's your shoulder? It's fine, it doesn't hurt. And they're living and they're compensating with a torn tendon. But as far as complications, again, you know, we don't want to do surgery if you're not having symptoms that warrant it. So if that 70-year-old patient, let's say, just by chance happened to get a random MRI of their shoulder and it showed a small tear, but they said, I have full motion, I have no pain, I can do everything I want, I'm sleeping through the night, it doesn't hurt, I would just tell them I wouldn't recommend surgery, but I would keep an eye on it. You know, if in 2 years from now, a year from now, 2 years from now, you're starting to get pain, you're starting to get weakness, we know you have a tear, it's probably getting bigger, and you just want to pay attention to that, because we don't want to see in 10 years when you know, unfortunately, I'll have ranchers that come in from like Bond or rural areas around us, and they'll come and say, Doc, I've had shoulder pain for 10 years and now I can't even lift my arm. By that point, options are limited. You know, usually we can't fix the tendon and they're looking at that reverse total shoulder replacement. So if someone's asymptomatic, they're 70, but we know they have a small tear, but it doesn't bother them, live with it, some therapy, keep strong. But if it's getting worse in terms of pain over time, you're getting weaker, then, you know, get it checked again. And we might shoot a repeat MRI 2 years later just to see if it's really progressing.
Okay, we have another participant who says that they're 70 years old, tore my bicep at least 10 years ago. It's been fine, just ugly. For the last several months, I have pain in the lower shoulder bicep area and throbs at night. What should I do?
Yeah, and that's, you know, unfortunately, well, if someone just presents to the office and you're 70 and you've torn your biceps, and for those people that don't know, if you tear the long head of the biceps, which is the one that tears, people come in with what's called, we call it the Popeye Deformities. So the muscle is sitting down in the arm, kind of bunched up at the bottom of the arm because the tendon is torn, and so the muscle has gone to the end of the arm. If it's just that, an isolated biceps, long head of biceps tear, people can do fine, because the biceps has two attachment sites. So there's this tendon in the front of the shoulder, which is the long head. And then there's another head that comes off this bone called the coracoid. So you kind of have a backup attachment site. So you can do fine with a biceps tear of your long head here, not at your elbow. If you tear that, you got to get that looked at. But this one up here, you can do fine. Having said that, there's a high incidence in people that are 70 that have a long-handed biceps tear that they also have a rotator cuff tear. So if this happened 10 years ago and you tore your biceps and ever since your shoulder hasn't hurt you, but now it's starting to hurt, that's probably your rotator cuff that's torn, that might have been torn years ago, but didn't bother you, but now it's getting bigger. So you want to get that looked at.
We have an individual who says, I injured my right shoulder during martial arts training during a fall. They tore their AC band and possibly their rotator cuff. And they have 3 questions. Can a partial tear at least 1/2 distance in length repair itself naturally? 2, what are exercises that we should do as we age to ensure avoiding rotator and AC band tears for active adults? And 3, do all AC tears at any length, whether repaired or not, are they susceptible to being retorn? And Dr. Cunningham, I can repeat those questions as you go through them.
Sure. Yeah. And we are talking about 2 different issues. So the acromioclavicular joint, AC joint injuries, and I'm sorry, this is the shoulder model. Again, that's where the collarbone meets the shoulder, and people disrupt these ligaments at the top of the shoulder. And they're very different than rotator cuff tears and how we treat them. We grade those on a 1 through 6 scale, and it really depends on where your collarbone comes across, how displaced it is, So the more displaced, the higher grade the tear, and the more displaced it is, usually it's surgical. So if it's just a mild sprain of your AC joint, a little separation, not surgery, type 1s and 2s, we don't do surgery on, but higher grade tears, we tend to fix those. Now I know this patient has not had surgery. It sounds like it was a low grade AC joint sprain. Those heal great. Low grade sprains, you might always have a bit of a bump here over your shoulder, but that's purely cosmetic. Usually people get back to full motion, no pain. But so those will naturally heal. Rotator cuff, that's a ligament tear though. AC joint injuries, that's a ligament tear, which are different. These tendon tears where the tendon is attached to a muscle and pulls away from the bone, kind of a different animal. And those don't heal themselves. Rotator cuff tendon tears do not heal themselves, but they may not progress. So if we saw an MRI where, let's say the tendon again is peeled up part way, but it's still attached, it may stay that way forever. But we're never going to see it typically, or I've never seen it in, thousands and thousands of MRIs where it's totally reseated itself and hooked back onto the bone. But if it's a low grade tear that we watch over time and it doesn't change, doesn't worsen, it's not causing you symptoms, then absolutely just let it heal on its own. When I say heal, it's not going to progress. Exercises. And maybe I'll turn that one over to Sarah just to talk about the best rotator cuff exercises for strengthening.
Yeah.
Yeah,
I mean, we do a lot for specific rotator cuff, your resisted external rotation. So keeping the elbow tight in at your side and then rotating out, and then keeping your elbow tight and rotating in. So we'll do those a lot of times with banded resistance, or you can lie on your side and do external rotation. And you can look up exercises for external rotation pretty easily as well. And then a lot of the other ones that we do is just for shoulder blade stability and actual shoulder blade strength. So working in between your shoulder blades. So anything where you're pulling straight back, pulling down, pulling from overhead down. So we kind of tell everyone pulling down and back. So you're trying to get those shoulder blades strong, pulling down and back. That's going to stabilize the shoulder joint. So it's not at risk, as at risk to be injured. And then also working that last rotator cuff muscle, which is that elevation. So using some good elevation if it doesn't hurt. That one can be a little tricky if your shoulder's irritated. So that's why I usually start with the rotations and pulling back, down and back, the rows, the lat pull downs, those kind of things. Because if you're elevating and it's pinching, that's not gonna be comfortable and can actually irritate your rotator cuff more. So you wanna work the rotations and the shoulder blade retractions more before that one.
And I think this person wants to know if those same exercises would apply to the AC band tears and rehab for that as well.
Yeah, I mean, we also see a bunch of those too. So AC separations can be a little bit more irritable on the external rotation as well, just because a lot of those muscles run past the AC joint. So working again, kind of the pulling, the rows, the shoulder blade extension, kind of those general shoulder blade muscles before the rotator cuff. And as the irritability goes down, you can work more into the rotator cuff.
And Dr. Cunningham, there was the last part to that question, just whether or not both those injuries are susceptible to re-tear, even if they've been repaired.
Yeah, the AC joint injuries, again, if those just heal on their own, the ligaments just heal on their own, they do great, and you're no more likely to ever hurt that AC joint than hurting your other side. Certainly, if you fell off your mountain bike hard and landed on the shoulder, you could re-tear the ligaments of the AC joint and re-injure them, of course. But once those are healed, the ligaments actually heal, if anything, a little tighter than they were, a little stiffer. As far as rotator cuff tears, you know, if once we get the tendon to heal, I tell people that you should do great. You should have no pain, full motion, as long as we can get everything to heal nicely. But I tell people, again, my simple analogy is it's that frayed rope. It's not the nice glistening rope. So it's susceptible. So if someone then went back to weight training 5 days a week and swimming, you know, long miles 3 days a week and really testing their shoulder, the tendon is not as healthy as it once was when we were younger. And so it can more easily get tendonitis and even re-tear with a lot of heavy repetitive overhead activity.
Do you have a recommendation for someone who would like to return to skiing but has some fear regarding a previously injured shoulder that has been repaired? Is there a type of brace that one could wear, like you have a brace for the knee when you go ski sometimes?
Yeah, you know, there's not a good type of brace for protecting you from rotator cuff injuries. There are braces that we use, like in, let's say, you know, this is a different patient, but like a 22-year-old that plays football, we might put them in a specific brace so they don't re-dislocate again. So there are braces that help prevent shoulder dislocations. But again, usually rotator cuff tears are not commonly traumatic. It's not usually a fall on the shoulder that causes these injuries. They're more of a wear and tear cause. And so you're more likely, if you're skiing, let's say on hard snow, and you have a hard fall on the shoulder, to fracture, to break your humerus, or to break your clavicle, or to separate your shoulder and hurt your AC joint. You're not as likely to tear your rotator cuff. So if you had a prior rotator cuff surgery, you know, unfortunately, there's not a good brace to prevent that. But number two, we don't tend to see them as being so much traumatic. They're more just wear and tear events that tear them. So.
I had a ski injury about 8 years ago. My shoulder took the fall. I was about 52 and active. It took a few weeks to settle down, but I would say it was 90% better. Recently, I took a fall on the steps, slipped out with socks on, and I went back, and I'm sure my shoulders took the fall. It's been really hurting at night. I still have pretty good movement, but occasionally it pops and snaps and it hurts. My range of movement is not 100%. I'm sure this is a rotator cuff tear. Does this sound like a simple tear, and have I caused more concerns by waiting 8 years to get it looked at? I'm still active, but the right shoulder hurts.
Yeah, and I'm sorry, Rachel, did they say that, I know they had the injury 8 years ago, but then they just more recently hurt the shoulder on the stairs, correct? And
let's see. Yeah, it said recently took a fall on the steps. Doesn't say specifically when, but.
Okay. Yeah, and if that person had told me, yeah, I had this bad fall 8 years ago, but then my shoulder recovered and I've done great and it hasn't bothered me ever since, but then I fell on the stairs. You know, and if you fell on the stairs 2 weeks ago and your shoulder's still sore, but you're slowly improving and getting that range of motion, I think it's okay to wait and just watch it, maybe therapy. But if it's, let's say your fall on the stairs was 4 months ago, you know, and you're saying it got better a little bit, but then it plateaued and ever since it's been painful, it wakes me up at night, it's weak, then I would get that checked out, because that's then more concerning for a rotator cuff tear.
Sarah, this one looks like it might be more for you. So this individual says the PT program I was on was largely using rubber stretch bands pulling from the doorknob and pulling outward with elbows to hips. But my left shoulder pops when I do the first exercise. My chiropractor says that's okay, but I felt it was making my pain worse, so I quit. I'm gradually getting better by doing nothing. Do you have any comments?
Yeah, I mean, that's a tough one without knowing kind of what's going on with the patient. They might have a little instability in that shoulder, and that's why they're getting popping. I'm not sure if they were seeing a PT as well as a chiropractor. Sounds like maybe they were. I lost that question. Oh yeah, so they were doing PT. Okay. So you might just have a little instability. So I'm not sure if they were working any stability exercises. So I do some weight bearing stuff. Yeah, they're hard to explain, but I do a couple more stability exercises. It sounds like they're mostly just doing that external rotation, reaching out, and that's the one that was popping. So maybe following up if you're still seeing the PT, asking if you can get any more stability exercises, or reach out to me or one of my coworkers, because I know we definitely prescribe some of those stabilizing drills. But yeah, I mean, there's definitely some popping if you have a rotator cuff tear because that shoulder is unstable. So figuring out the right exercise program that's for you and hopefully not irritating anything. So
another question. If I fell in October and I'm feeling better now than I was back then, still sore, loss of some motion, but gaining it back. This person is 53, no severe pain right away, wants to know what your thoughts are, Dr. Cunningham, if maybe if this person should come in and get it checked out.
Yeah, and I think, yeah, so fall was in October, so we're getting on there, 3 months, let's say. You know, at 3 months, it's a little bit of a gray area. You know, at 4 months, if people said, you know, I'm not improving any longer, I'm continuing to have pain, I still have some stiffness, some weakness, I would get that checked out. You know, at 2 months, I would say, continue, if you're seeing improvement, continue with your therapy. And then, you know, if you have full recovery of function and no pain, great. Then, but it's really, we want to just continue to see that progression where you're getting, you know, pain-free, full motion back, good strength back, no pain. And if at a certain, you know, if certainly 3 months is starting to get worrisome, if you're still having symptoms, that you probably should come in and get evaluated. 4 months, I definitely would.
Another person asked, if my job requires that I lift 50 pounds over my shoulder, how long will I expect to heal after a rotator cuff repair?
To get that ability back to lift 50 pounds over their shoulder, yeah, that's a tough one. A little bit depends on a couple factors. So how old are you? You know, if you're a 50-year-old, your rates of healing are great. And, but just that stress of lifting 50 pounds overhead, that's really the last thing to come, as is repetitive overhead sports. So, you know, you'll probably be under, honestly, some weight restrictions short of 50 pounds up until even 6 months until you could do that. I'd let you lift 50 pounds below shoulder level with a single tendon tear that was repaired, probably at around 3.5 months, something like that, 4 months. But to lift it overhead, you're probably looking at about 6 months for, let's say, a supraspinatus tear, a single tendon tear. Longer if it's, let's say you had a 3 tendon tear, a much larger repair, then you're probably looking even at 8 months.
Another person asked, have the slings improved? I had one that really aggravated my neck.
Yeah, we actually have gone to recently a new sling, and I think it's much better. Patients seem to like it more. And instead of being suspended off their neck, you know, and slinging this side and suspend off the neck, it's actually suspended off their shoulder on their other side. So it loops over the shoulder and it's suspended that way, and it's much better tolerated because that strap isn't digging into your neck.
Got a couple more, Dr. Cunningham. Is that all right?
Sure.
Okay. A couple more about surgery. A couple people are asking what the pain is like from surgery and what the recovery time is like and what they should expect. Okay,
yeah, and we'll just take kind of your average patient. So let's say 60-year-old with supraspinatus tear. So they're going to go home the same day. They'll be in a sling for 6 weeks. We'll start pendulum exercises right after surgery. I should speak quickly that we'd recommend that you have a pain block in surgery where you have that catheter. And so for the first 2-3 days, you have usually no pain because your arm is totally numb, your shoulder is totally numb. It's kind of a weird feeling though, because you can't move your hand. I tell people it's kind of like a dead piece of wood, your whole arm. And then on the third day, anesthesia would have you pull that catheter out. It just slips right out of your skin. Then you'll start to get your sensation back. The pain will come back as a result. But when we've gotten you through the first 3 days, that's the worst part. So the worst part is behind you. But then patients might need some pain pills to get to sleep at night. Hopefully not a whole lot of that during the day, but maybe a pain pill during the day, maybe a pain pill or two at night to get through the night. After a week of that, hopefully you're off pain pills entirely. You're just icing the shoulder, maybe sleeping in that recliner chair for the first few weeks though. I typically hold off on the physical therapy for the first 4 to 6 weeks. You know, if someone, let's say, knew Sarah, I know Sarah, I trust her, I don't mind that, but a lot of my patients are traveling out of state or down to the Front Range, and I don't know all the therapists, and I just don't want them to do too much too soon. So we typically just have people do pendulum exercises for the first 4 to 6 weeks and then start therapy. And then we'll get that range of motion back with Sarah laying you down, stretching your shoulder. And then by 8 weeks, you're raising the arm yourself. By 9 weeks, you're working on those bands to get strong. By 12 weeks, most patients would come into the office and say, I've got full motion, I have no pain. I'm sleeping through the night. I'm not really thinking about my shoulder that much anymore. It's just weak. And to get full strength back can take like 6 to 9 months. But I tell people that in a lot of these cases, these tears have been present for a few years and they've gotten bigger over a couple of years. So you've lost strength over a number of years. And so to get it back, it can take sometimes in big tears, even up to a full year.
I just want to read a comment from somebody and then I have one more question for you.
Sure.
So one individual says, I received a steroid shot from Dr. Cunningham post-surgery, almost 12 months from a different surgeon. It worked wonders. Thanks so much, Dr. Cunningham.
Oh, good. Great, thanks.
And then another question, how long does it usually take from a tear to atrophy with no hope for surgery?
Yeah, that's a good question. And the studies are, they're variable on that, but basically, so the 2 criteria that we're gonna see in order to start that atrophy process is a full thickness tear. So the tendon has to fully retract from the bone or come off the bone, such that the muscle again isn't activating. We're not able, you know, you're raising your arm, but that, I tell people it's like the lamp is unplugged from the wall, you know, the light bulb isn't coming on, the muscle is not seeing nervous input of any kind. So the muscle's not firing. So the muscle is just quiescent. And then you're going to start to see that atrophy develop immediately. I would say we'll see muscle atrophy where those muscle cells are kind of shrinking. But in order to replace with fat and get that fatty atrophy, that usually does take a couple of years.
Looks like we did have 2 last minute questions come in. Do you think we have time to read them, Dr. Cunningham?
Sure.
Okay. I had a rotator cuff surgery 3 years ago at age 57, 2 torn ligaments, 1 severed ligament, and torn bicep tendon, and have recovered to about 90%, but I've had itching at 2 of the arthroscopic entry holes ever since. What can I do about that?
Yeah, that's unusual. That is unusual. I don't, because I've done thousands of these repairs, and you know, normally my patients that I would see back would tell me at some point, like, why the heck does this itch? You know, we do use suture material to close these little portals, but the suture material is absorbable. Some people react to that suture material, and but normally the suture material has resorbed and it's gone within about 3-4 months. So if you're having itching and it's years later, that is really unusual. You know, you might have people might get some itching in the first couple of months just from that suture breaking down under their skin. But again, usually by 3-4 months, it's resorbed, it's gone. I would probably, you know, come see me. We'll probably put a little injection around the portal, a little steroid injection to see if we can calm down whatever might be inflaming that area and causing itching. But that's not something we typically see.
We have one more question. Do you still use the pillow block, which is under armpit, keeping the arm up at a 90-degree angle?
Yeah, so that's that sling where basically your arm is held out to the side. We only use those in large retracted tears. So if that tendon is pulled off the bone, but it comes back down without any tension in the repair, no pillow at your side. If that tendon's back here and I'm able to mobilize it and get it over and there's some tension in the repair, we want to put you in the pillow to take tension off the repair to give it a higher chance of healing. So it really depends on the tear size and how retracted it is. You know, the bigger the tear, the more retracted tears, they get the pillow.
That's pretty much it for questions. And just so everybody knows, we are going to take all these questions and we're going to answer all of them and put them up on our blog. So keep an eye out for that in the next week or two. We're also going to have a recorded version of this webinar on YouTube that'll be posted by tomorrow. And we're going to go ahead and send everybody a link to that YouTube video who signed up for the webinar. So keep an eye out for that. I'm sending everybody links to Avalanche and VSO's website right now, so you can follow up if you want any additional information. If you would like to be contacted for an appointment with Dr. Cunningham or with Sarah or with any of our other specialists, please feel free to call us at the phone numbers on our website. You can also reply directly to the email, the confirmation email that you got when you signed up for this webinar. And we'll be responding to those as well. And you can also reply to that email if you have any other questions.
Great. Thanks, Rachel. Thanks, Sarah. Thanks, everybody.
Thank you.
Thanks so much.